Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there. Thank you so much for being a part of our day today. Dr. Juliff certainly appreciates when you show up and hang out with us for a while. I can guarantee you one thing. Every single show is different. When we first started to get the show going like a year ago, we just said, hey, what are we going to do? How are we going to talk about veins, and how are we going to talk about veins for an hour? Well, it turns out that every time we do a show, we run out of time. So it is not for lack of finding the words, but to put them in the right order is very important. And many of you have heard over the time that we talk about DVT, about clots, and about deep vein thrombosis, and all of these things that I'm now a master at because of Dr. Juliff. And so I'm not even going to pretend, Doc, that I know this stuff. But I have learned a lot, and one of the things we're going to talk about today, I am a patient, not only a facilitator of the show, everybody, but I'm also a patient of the Vein Clinics of Hawaii, and I am on blood thinners. And I'm so pleased because it seems like every time you turn on a TV at night now, you see something about blood thinners. It's not that it's a darling drug. It's that more and more of us, I guess, need blood thinners. What are they in the first place?
Yeah, you're right. You've been hearing more and more about blood thinners. Now, part of that is because there are some newer medications that have just come out over the past 10, 15 years, and those are the advertisements that you hear because they're pushing these new medications, which is just one of the things, one of the medical type products that are used to thin blood in one way or another. But, blood thinners basically prevent the blood from clotting. And what do we use blood thinners for? Mm-hmm. Well, we're using them
because I always thought that clotting was a good thing. I need to clot. So what do you mean? I'm not going to clot as easy. What's the deal here, right?
There are certain situations where your body is sort of set up to develop clot or create clot in an abnormal sort of fashion or a location, and we'll talk about some of those things. Blood thinners are used to either treat a problem or to prevent a problem. Mm-hmm. Now, what are the problems? Basically, what are the problems that they treat? Well, they treat blood clot when it's happening in an area where we don't want blood clot to form.
Clotting is good sometimes, and clotting is like really bad sometimes. It depends, right?
Yeah. So, we talk a lot about DVT, deep veins thrombosis, and, the lower extremity is probably the most common site that we see that, but abnormal blood clot can form in other areas too. It can start in the legs and go to the lung. It can, vein clot can occur in the upper extremity, in the arm and neck, and even blood clot can form in the abdominal cavity within the what we call mesenteric circulation, which is the circulation that goes to the bowels. So that creates a whole different other problem, but abnormal blood clot can form in a variety of different locations where we don't want it.
One of the things that I've learned, and since you talked about it, you mentioned early lower extremities. I had a really interesting experience the other day from a listener who wanted to know if his condition was something that you would look at, and I thought, well, he's actually a diabetic, and he has regular type 1 diabetes. He's had it all his life. He had a really interesting thing happen to him, and that was he was walking along the beach and barefoot, and he stepped on something that sort of poked him, but he looked and he didn't see anything. When he was driving home about an hour later, he noticed the floor of his car was wet. his foot had been bleeding a lot in his car.
Yeah.
And he had no idea. And this is, and he is on blood thinners. So he said, I think it's because of the blood thinners, not necessarily the diabetes, that I just kept on bleeding.
Well, yeah, a couple things there. Yeah, well, right, he's right about that. If he's on blood thinner, obviously it's going to be harder for his body to form clots that should be formed, but
which he really needed, right?
Yeah, at that point he did. But the flip or the other side of that story is that diabetics, they develop neuropathy. They don't feel their feet as well as they should, and so that's a very, very common scenario where somebody hurts their foot. They don't even know it, But he should come in. We can kind of help him put it all together.
Yeah, and gang, one of the reasons why we're doing this today is because there are so many processes that go on in diagnosing vein disease, and a lot of them also have similar situations and symptoms for other diseases. And so it's by the joint efforts of guys like Dr. Juleff and your primary care physician and maybe a oncologist or maybe a diabetes guy that sooner or later, one of these spurts, which we call them, one of these experts is going to find out what's wrong with this patient or with me and is going to guide me along the line for either healing or at least managing the situation.
Yeah. And people have plenty of different types of problems, and it often takes different types of doctors to kind of come together and bring it all together and come up with a solution. But so we treat conditions with blood thinners. We also try to prevent certain conditions with blood thinner, and that also has to do with blood clot formation. Something else that I think people are hearing more and more about these days, and I think also it's primarily because of the blood thinner marketing, but there's something called atrial fibrillation.
Yeah, everybody talks about that now. I could hardly pronounce it, let alone know what it was. Now everybody seems to be at least addressing what is that. Anyway.
Yeah, and it's a fairly common it's not an uncommon thing. Plenty of people out there that have atrial fibrillation, and I think most people know that there are there are 4 chambers of the heart, 2 on the top, 2 on the bottom. And, both of those chambers, when the heart is functioning normally, all the chambers contract at a little different time to make the blood go through. But in atrial fibrillation, it has to do with the upper chambers of the heart that are not contracting the way they should. So when those upper chambers don't contract, there's a certain amount of blood that kind of can stagnate in various parts of the atrium, and clot can form. And that's obviously an abnormal place for clot to form. We don't want it to form.
And by the way, gang, I'm here, sitting here, just waiting for my opportunity to drop on in because that's where I was. And I want to tell you that the treatment that I received and the medication that I'm on, this thing called AFib, which can be a real showstopper, at least in my condition, in my situation, seemed to be under control, not only by treatment, but by ongoing use of a blood thinner, which seems to be doing, knock on wood and praise the Lord, what it's supposed to do. So these are the victories that you have as a doctor, right?
Right.
And for me as a patient, the same thing. So, yet you're warned a lot, that just doesn't mean you go merrily on your way taking this stuff forever.
Yeah, well, it always has to be monitored. There's no question about that. But the other thing I wanted to mention about atrial fibrillation is that there's a lot of people out there who feel like, gee, they haven't had a problem in the past, so they're not going to take blood thinners or appropriate medication. And atrial fibrillation, specifically, is something that can be lethal if you form a clot and it can go to the brain or somewhere else and, create a terrible stroke or even, again, lead to death. So atrial fibrillation is one of those things that you really need to know about. And talk to your doctor and find out if you should be on a blood thinner. There's another, that has to do with the atria. Well, sometimes the lower chambers, which are called the ventricles, sometimes those don't contract or work as well as they should, and that can be also a source of clot formation. There are some people who form clot easier than they should, and most of the time it's a genetic sort of thing. We call those people they're hypercoagulable. They coagulate too much, and if you're one of those people, you might need to be on a blood thinner. You may or may not, but it's something that needs to be addressed and evaluated. Patients in the hospital, just by virtue of the fact that they're in the hospital, they're at a risk for developing DVT. Those people should be on some form of blood thinner. And also the other thing that we worry about with respect to hospitalized patients are those people that are undergoing specific surgeries, especially orthopedic and pelvic type procedures. They need to be on a blood thinner prophylactically because the rate of DVT after those particular surgical procedures is very high.
Yeah, very amazing. And by the way, the other thing is, and I think maybe, Doc, you can explain it, you talking about earlier, there have been blood thinners around for a long time, but there's this new wave or this new rash of them, that the ones you see advertising on television.
Right.
All the time. They seem to be a collective result of a lot of work and experimentation and clinical tests and everything else to look at these as maybe the new generation of blood thinners.
Oh, they are. Yeah, there's no question about it. There are some definite advantages to those medications as opposed to the the medications that we've had in the past, and we're going to talk about that also a little later. So the other thing, we've been talking about kind of the heart and the vein side of it. We also might use a blood thinner to protect people from the arterial side.
Yeah, there you go.
So and that's where heart attack and plaque and that kind of thing. Heart attack and stroke can occur. And usually what happens is that when there's disease in an artery, it has to do with plaque formation. So for those that don't know what plaque is, what is it and where does it collect? It collects in the wall.
Inside the vein.
Inside the artery.
The artery, I'm sorry.
Inside the artery, and it's a collection of fatty molecules and calcium and various things, inflammatory molecules, but it creates a narrowing of the artery.
So let's say that you got a heart that's trying to pump blood out of there, and it's going into this artery that is constricted. And if your heart doesn't get stronger, aren't you at a risk of not getting enough circulation?
That, the plaque can build up to the point where it's not allowing enough blood to go through. That's one thing can happen. But the more common thing that happens is that those plaques can break down. They crack or they ulcerate, and that's basically what we're trying to protect people from. When that plaque will ulcerate, then the surface becomes real rough, and fresh clot can then form on that, and it often forms very suddenly, boom, like that, and that's often the cause for people having heart attacks.
Yeah, and this is something, but the interesting thing is, it's not one cure fix all, right? I mean, in other words, just because you saw this really sexy looking medicine on television doesn't mean my problems are over. I'll take that stuff. We're done.
Yeah, that's a good point. Each one of these situations, the number of things that we've talked about already, each one responds better to a different medication. Yeah. Some of them very cheap and on the shelf at your drugstore, or some very expensive.
I love the ones that say, if you can't afford this medicine, so and so might be able to help. Yeah. They'll be, but I'm telling you, isn't it awful when people either self-diagnose or can't afford the specific medicine that they need and try to make up their own plan B? And another thing that circulates around, and I know that a lot of us listening to the program, and a lot of us is, we got bucket lists of things that we want to do. We want to do a lot of traveling. Talk about how maybe sometimes you'll be put on a blood thinner when you're going to travel because you are even at a higher risk of a clot, being sedentary 8-9 hours on a plane, and these kind of things that we talk about in the past.
Yeah, typically we don't give somebody on an as needed sort of basis blood thinners, because they have to be better controlled. However, I was getting on a plane here not too long ago, and there was a couple behind me, and the husband was saying to the wife, "Oh, do you have the medications for this flight?" Yeah. And I was thinking, well, they wanted to take some Ativan or a sleeping medication or whatever, and she said, "Oh yeah, I have the blood thinners." So that would be something that I would not recommend.
Yeah, but here's something that I think you would, and I'm a patient, so I know this. If you are not a regular wearer of compression stockings and you're going to travel, guess what? You should wear the stockings.
Yeah,
that's I do. And it's the ones that I'm getting that I got from your office, the latest batch of these knee-high things with the opening for the toes. Unbelievable. Easy to put on. You can wear them all day. They don't throb. They don't hurt. There's a big change in that area too, isn't there?
Yeah. And you're right. That's the way to protect yourself from DVT if you're taking a long plane ride, or if you're going to be immobilized in one way or another. So what do blood thinners actually do? Do they make we hear this question all the time, do they really make the blood thinner? They don't. I mean, that's kind of just the nomenclature. If you look at the blood of a patient on a blood thinner and look at the blood of a patient not on a blood thinner,
pretty much
it looks and feels the same. Yeah. So basically, a blood thinner is a medication that's going to interfere with clot formation in one way or another. And there's a variety of different ways that can happen. And it all depends on, the medication and what it's kind of directed to.
As a layperson, I would think, all right, well, maybe that's like a lubricant. Maybe I take this stuff and it adds into my blood and it makes my blood slipperier, so it travels, so it gets unimpeded.
Actually, there are medications like that. They're not really referred to or considered a blood thinner. We're not going to be talking about those today, but there are some medications that make the blood cells a little slipperier and allows it to get into the circulation a little easier, so you don't have symptoms of lack of blood flow.
Okay, so if they're not actually thinner blood, why are we calling it blood thinners? I
don't know.
Okay,
that's a good question.
Inquiring minds want to know.
Yeah,
but the fact of the matter is that they and it's like a lot of other things that we talk about in your practice. And by the way, if you want to learn more, I suggest you go to veinclinicsofhawaii.com. veinclinicsofhawaii.com. Lots of stuff going on there. And some really fun stuff too, and yet a feeling of good sense and well-being is if you can get into one of the clinics and see for yourself, like I do, what the people are like. So please remember that. Go to veinclinicsofhawaii.com. So, in other words, talk about the circuitous route you're going to. Before you put somebody on one of these blood thinners, you're talking about what do they actually do? Well, if they're not actually thinning your blood, what are they doing?
Yeah, they act in different ways, and they can either affect blood cells. There are blood cells that are specific blood cells, and we're going to talk about that in just 1 minute, that have to do with clot formation. Some of them interfere with that. A second way is that they interfere with proteins in the blood that have a different role in creating clot. Some of them benefit or help the anticoagulation system within the blood. We've talked about this before, where we have a clotting system in our blood to form clot when we need to have it formed. And then we have a system within our body also that keeps that system in check, because you don't want to overclot, because that would be fatal. I mean, if you the way that the clotting system works is that it just keeps going, it keeps rolling if there's nothing that's going to stop it. So there are mechanisms within our blood that will keep that in check. Some of the medications help that.
Actually, do you think? Isn't it an exciting time? Because we're talking about some of the massive paradigm changes that have been in your field with diagnostics and with treatment and with, in non-invasive procedures. Isn't it neat that the prescription drug business is keeping up with the need to join the party?
There's always, there's new stuff coming out.
The reason I asked that is because it was just last night, knowing that we were going to do the show today, that I saw an ad for Bayer. And it just said, we've been around forever. We just want to thank you, and we're still around. And when you think about it, they have been around forever.
Yeah,
and they're still prescribed in mini doses. Are you on an aspirin regimen? When people say aspirin, they're thinking Bayer.
Yeah,
that's interesting.
And it's funny you bring that up, because that's the first thing we're going to talk about is aspirin.
Yeah,
and even though it's an over the counter kind of medication, or thing.
Yeah.
Typically you don't think anything about taking an aspirin here or there, but you do have to keep in mind that it is a drug.
Yeah.
And it should be used. It has a benefit, but it also possibly could have a downside.
Yeah.
And it's used, in specific situations. Many people are on a daily aspirin these days. That's very, very common. And you have to weigh the risk and benefit because there are benefits.
Sure.
But there's also, even though it's just an aspirin, there are some potential risks there too.
And that I've always found that interesting because I do know that a lot of my friends and a lot of listeners, a lot of you out there that are on an aspirin regimen, you're on that little 81, whatever it is,
right.
The little tiny thing. And you think, well, it's just such a tiny little thing. How can this help me? It's funny because another medication that I'm taking is also a tiny little thing. And the doctor said, okay, you got to go down to half that. And I think, wait a minute, it's a dinko thing in the first place.
Yeah.
He said, well, your situation suggests that.
Mm-hmm. Right.
And so this is something that you go through on a regular basis too.
Sure.
And I'm sure that one of the things you're going to talk about is, wait a minute. Sometimes people don't even remember that they're doing that. So when they're in your office filling out what are you taking, they forget that aspirin they're taking, that they're taking every night.
Yeah, again, because people don't really think of it as a drug. Yeah. They think of it as something that it's over the counter. They pay for it themselves, and it doesn't really count as a medication. But it does.
It does.
Yeah. So how does aspirin work? Well, aspirin works by inhibiting platelets, and platelets are a specific type of blood cell. Our blood is made up of serum, which is just kind of a clear, cloudy
liquid,
kind of fluid. Red blood cells; those are the blood cells that carry the oxygen. There are white blood cells that has to do with the immune response, and then there are these things called platelets, and they're little cells, blood cells that are very important and intricate to the clotting process.
And by the way, what Doc is talking about is why when you give blood, when you donate blood, like to the blood bank or something, they say that one donation can save 3 lives because it depends on what part of that is interesting. Does taking these medications affect the quality of your blood?
The quality? You mean the
desirability of it for instance, to give to somebody that needs it, or do they take that out of it? Do they filter your blood before they put it in somebody else?
Yeah, typically most of those medications are not going to have a bearing on that.
Mm-hmm.
Yeah,
interesting. Good.
Yeah. So platelets aspirin interferes with platelets. Platelets are intricate to clotting, so if you interfere with platelets, you're going to interfere with clotting. Yeah. And aspirin is used more so in the protection of that plaque, that arterial plaque, thrombus we were talking about in heart attack and stroke. Since it's what happens with that plaque is that it cracks or it breaks, it becomes rough on the surface, and the first thing that happens is that platelets can attach to that because it is a rough surface. Yeah. And so aspirin is used specifically for those situations where we're trying to prevent heart attack and stroke, especially if the patient has already had a heart attack or stroke.
Interestingly enough, and maybe you can, I'm sure there are people out there saying, well, wait a minute, I've always taken aspirin for a headache or for a hurt. And isn't that really what most people think that's all aspirin is?
Yes. Yeah. A lot of people take it that way, sure. Yeah. If we're not talking with respect to the downside to aspirin, we're not talking about those people that take it periodically for a headache or whatever. Our comments today are more directed to those people who are taking aspirin every day. So, so we use it for arterial problems, especially in the heart attack, in the brain, for stroke, but also wherever there might be arterial disease in the body, intra-abdominal organs or lower extremities, etc. There are situations where we may want to have that antiplatelet effect of aspirin, and they will ultimately, hopefully, benefit from it. Now, is aspirin good to protect somebody from venous clotting, from DVT? No, it's not.
Interesting.
So, in a lot of people, I think a lot of people are under the false impression that, an aspirin is going to be good for that, but it's not really giving you any substantial amount of protection from forming a DVT. Again, if you're laid up in the hospital or laid up at home or on a long plane ride or whatever.
Yeah. Boy, that's interesting, because that's maybe why some of these new medications, isn't it, by the way, a game changer? When you say it may prevent a heart attack, let's say if you already had one,
right?
Then now it's a game changer.
Yes,
you really need to have a different sort of lifestyle to avoid having another one of these things, right? So that's where some of this stuff comes in. We're talking about,
and that's a very good point, Mike, because that's what we're going to talk about here right now. Is it used to prevent heart attack and stroke? Yeah. And in the past, it was used much more, more universally, especially, in treating adult patients, middle-aged and beyond and elderly. Everybody got thrown on an aspirin, whether they have had heart disease or stroke or not. Well, in more recent years, and by what I mean by that is probably just the last, 3-4 years, there have been some studies that have shown that maybe the benefit of aspirin is not what we thought it was, especially if you compare it to the risk. Because, again, we sort of underestimate taking an aspirin every day. Yeah. And there are some bleeding risks that come along with that. And so you have to make sure that, when you're treating any one particular patient, that patient is getting adequate benefit for the risk that they're undertaking by taking that medication.
Yeah, that's very interesting, because and we're all victims of the press. I mean, there's stories that'll come out and either put people off something forever that shouldn't. But then there's another thing saying, well, you got to really be careful about stomach ulcers. If you take aspirin, you're going to get stomach ulcer. What's that thought? I mean, when you take anything, the stomach ulcer, when we talk about ulcers in your world, we're not talking about the peptic stomach ulcer somebody gets. Yeah. We're talking about a hole in their leg,
right?
Which we're going to talk about. It's a vein problem.
Yeah.
But isn't that interesting that they'll tell you that if overtaking aspirin for whatever reason it's, I guess, caustic to some. It'll actually cause problems.
It can be hard on the stomach lining, along with other medications like the ibuprofen. The so-called non-steroidal anti-inflammatory medications also are very hard on the lining of the stomach. So you have to, that's a good point, because that falls under the category of potential risk for any one particular patient. So who should be taking aspirin now on a daily basis, and who are the people that are really going to benefit from it? I think that we have found that it's not an adequate medication, or it's not an appropriate medication to be taking for everybody just to prevent heart attack and stroke in the future. However, if you've already had a heart attack or a stroke, then you probably should be on aspirin daily, and that is going to afford you some protection from it happening again. And even though there is some risk, the benefit outweighs the risk.
When you do a blood test or when you have lab work done, there are certain things that, as a physician, you look for to find out what range is this person into that. And is it that some of these medications you're talking about, whether it's a vitamin supplement or something like aspirin, can immediately alter what the blood test said you had? It's a fixer, and yet what you're saying is it is a fixer, but you also have to weigh, well, if it's fixing one thing, it's breaking something else. We have to fight. It's a thin road, isn't it, sometimes?
Well, yeah, it is, because you don't know which is going to be reality for that particular patient. Maybe in that particular patient, it is going to prevent a stroke in the future. But you never know. You can't count that. On the other hand, if you know that an aspirin is going to cause abnormal bleeding in any one particular patient, obviously you're not going to prescribe that patient aspirin. But you don't know that beforehand either.
Pretty interesting.
So that's why you have to rely on statistics.
So the who should take it? It might be a pretty wide list.
Yeah, well, those people who have had a heart attack and stroke already, those people who have had a heart attack and have had either coronary bypass surgery or coronary stent placement, they are also going to benefit from.
For those who don't know what a stent is, what's a stent?
A stent is a little, wire mesh, a tiny little wire mesh thing that goes in. It's placed percutaneously, so we go through an artery with a long catheter, a long tube, and it gets placed inside the small arteries of the heart, the coronary arteries, and then we project that stent and then expand the stent inside the artery.
Fantastic.
in the area where a plaque has formed. Basically, that's getting back to plaques. That's where stents are placed, and it expands that area to open the artery and also to stabilize that plaque so that it doesn't become unstable and then lead to clot formation.
Yeah, and by the way, this is another thing that we talk about. Like everybody talks about it like it's easy to understand. When you look at what it took to develop that, and how common it is now for surgeons like yourself to use these things that weren't even available. When a lot of the doctors today went into medical school, these things didn't even exist.
Yeah. Well, when I first started. Giving away my age, but when I first, or when
as a coronary surgeon, now you're talking about a cardiac.
No, actually, even before that, when I was in general surgery, we do general surgery training before we do cardiac surgery training. But when I was in, general surgery training, so this was, early to mid '80s,
a while ago,
we were, they were just starting to use stents, and I mean, development of medical devices is an extremely interesting thing. All I can say is we've come a long way, baby.
Yeah, I was going to say that. Weren't there a lot of the older folks? No, that's no good. Yeah. That doesn't work. It sounds too good to be true. Yeah. A lot of these things have paid their dues.
In the very early years of stents, often it wasn't too good to be true because there were a lot of problems with it. But that technology has been made so much better, and people can very reliably undergo stent placement for whatever. But so if you've had a heart attack or a stroke, you need it. If you have a coronary stent or any kind of stent, an antiplatelet medication is good. If you have not had a heart attack and stroke, but you are at a very high risk. If you're in a very high risk level, your parents had arterial disease and you have diabetes and other things, then probably for those people it's also appropriate. But if you don't have a risk, you haven't had arterial problems of those sorts in the past, probably it's not worth the risk.
Yeah, interesting. And by the way, this is all risk. And what I really enjoy is learning how the different specialists, like Dr. Juleff and others, are able to coordinate activities and to really work collectively on a patient. I don't think that opportunity was around back in the day either. Usually, one doctor took care of everything that was wrong with you.
Yeah, it's been nice to have people who are, authorities in their little niche within medicine. It's made it so much better.
What about some of these other things that we're going to talk about? Some of these other magic things, these drugs.
So the next one, the next step up is a medication called Plavix, and that's the most common of this sort of medication. There's a couple of other ones that are very similar to it, but Plavix is like aspirin, although much, much more effective. So it's kind of like aspirin on steroids.
Wow.
And it's also an antiplatelet agent. It has a much greater effect, a much greater antiplatelet effect than just aspirin. So it becomes even more imperative that you understand the risk of being on Plavix.
I would imagine this is highly monitored when you're a patient on it. Or should be, anyway.
Well, monitored for there are blood tests that can be done to look at how much antiplatelet activity is going on in your body. Typically, those aren't done routinely to follow somebody that's on Plavix. However, you have to pay attention to symptoms and make sure that any one individual is not having potential concerns with that with the downside.
I was asked by somebody, and I saw this in our materials also, that in many respects, when you take a look at this, what indicates when it is. You're looking at, is Plavix a preventative medicine rather than a post-event medicine?
Well, a little bit of both, but it's more of a preventative medicine. Yeah, so we use Plavix also to prevent heart attack and
so
stroke.
typically, am I right that it's probably going to be your cardiologist that determines when somebody takes Plavix, or
Yeah,
I mean you do it anyway because you walk in all of these fields, but some people don't. I mean, some people that would maybe not be the first on their prescription list.
Yeah, I think probably as a group, cardiologists would be the ones using Plavix the most, because not only are they using it for those patients to prevent, arterial events, but Plavix is probably the drug over aspirin that's used a little more commonly in people who have had a stent, a coronary stent. I mean, Plavix is sort of the main medication that's used to prevent clotting of that stent over a long period of time.
Are there yabuts about Plavix? When I say yabuts, yeah, but I know it's good for this, but
yeah,
I'm imagining that there must be.
Yeah, well, yeah, definitely, because Plavix, like I said, is much more effective in its antiplatelet activity, and it really does, thin the blood. So, back when I was still working in the hospital, could Plavix, be an unwanted evil? Yes, if somebody needs emergency surgery, and I can remember back when I was doing heart surgery, a
lot of heart surgery is emergency surgery, right?
A good amount of it is. Yeah. And the first question that always came out of our mouths is the patient on Plavix? Because so many of those cardiac patients are on Plavix for one reason or another. Most of the time it's because they've had stents put in and that kind of thing. So, and operating on somebody, it really is a marked difference. For instance, let's say operating on somebody who's just on aspirin as opposed to operating on somebody who's on Plavix. I mean, they're worlds apart. Yeah. And Plavix really does, thin the blood, and it can be problematic if you need emergency surgery. So that's one of the downsides.
Now, let's say that a surgeon finds out, or it is determined, that person is on these things. Would there be sometimes a way to, what's the risk? I mean, do we still have to do this guy right now?
Right.
Or can we wait a little while? Can we get some of that out of his system before we do that?
Yeah, that's what it boils down to. How emergent is that procedure? And, if you're going to wait, however, it takes, 7 to 10 days for that Plavix to kind of
I was thinking a couple hours,
Yeah, because it knocks out the function of the platelet permanently, any one platelet cell. Yeah. So you really have to wait for your body to rejuvenate or redevelop new platelets. That takes a week and a half to 2. So. Wow.
So when you're on a gurney, you can't wait that long.
Sometimes you can't. Sometimes you can. You have to just to deal with it, and then after the procedure, you have to give the patient platelets. We can replace platelets, but it still can be a little problematic.
Yeah. So if you're used to donate again, man.
Yeah.
Somebody might need those platelets.
Yeah, and actually, platelets are a much lesser. They're we have a hard time keeping up. Blood banks have a hard time keeping up with the supply of blood, of platelets, as opposed to red blood cells and other things.
Yeah, and by the way, if you're listening on Oahu, which most of you are, I know the blood bank from experience. They need like 200 pints of blood a day. I mean, there's no waiting for blood. You need to do that. Right.
Yeah, when you need it, you really need it. So the next category of medications is something that we call heparin. And I think many people have heard of this thing, heparin. It's a blood thinner. Heparin is a medication that's used primarily in the hospital, and typically it's given as an IV infusion. So typically you start an IV and you're dripping heparin at a specific rate. We have to keep a very close eye on that, but that can bring about pretty complete what we call systemic anticoagulation. The whole body is becoming anticoagulated, and it happens over a pretty short period of time. Yeah. So if somebody comes into the hospital and needs an immediate way to thin their blood for whatever reason, heparin is often used in an IV way to make that happen.
So when somebody goes into an ER, for instance, and they and that team is around you, taking a look at you, is that when somebody will say, "Start this guy on this, get this guy on heparin, or whatever"?
Once a diagnosis is made. And heparin in that setting was used a little more commonly in the past, and we'll talk about that in a second here. But often in treating many forms of DVT, heparin was the initial medication that we gave. So what does heparin do? Well, heparin is one of those medications that helps or potentiates that anti-clotting check system. Within our body. So again, we've got proteins and things that cause the blood to clot if they're activated, and then we have proteins and other things that prevent the blood from clotting. And there's something called antithrombin 3. We call it antithrombin because thrombin is one of those things that causes clotting. And so heparin actually potentiates the activity of antithrombin 3.
Okay, so
that's how it works.
That's it. Would you say that's the primary function?
That is the primary function. Yeah. Well, it does other things too, but that's the primary function. Again, the effect is immediate, and for many, many years, it was used for people with DVT. Now, fortunately, many people with DVT, we don't have to put them in the hospital anymore because we've got other ways to thin their blood pretty quickly and in a uniform sort of fashion. We'll talk about that in a minute. But we often needed a bridge. We needed a medication bridge from being treated with nothing to an oral medication, which the patient would then go home on. Yeah. And heparin was that medication.
Which is a good thing. We all want to go home, but we want to go home and stay healthy while we're there. Right?
Yeah. Make sure that you're stable with respect to whatever it is that's being treated. So it's not needed so much anymore. We mentioned that. And it was being used as a bridge to Coumadin.
We've all heard of that Coumadin.
Or warfarin. And we're going to talk about that in a minute. But, for many, many years, Coumadin was the main medication that we used to treat DVT for a long period of time. But Coumadin takes a while for it to kick in completely. And so we needed that bridge of a medication that got you from, not being anticoagulated to being fully anticoagulated with Coumadin.
And then isn't it also then interesting that you don't want to continue on that because that too much is no good too. Too much is not good as well. So you just got to get to that right place.
Yeah. Since the effect of heparin happens immediately, it was an ideal medication for people to be put on when they came into the hospital and it was found out that they had a deep venous thrombosis or a blood clot of whatever, in whatever form. The one of the drawbacks to heparin is that it needs to be monitored very closely. So
that's why you say mainly it's applied when somebody is in the hospital.
In the hospital,
we'll keep an eye on them.
People get put on heparin and then, for the first 24, 48 hours, they may be having their blood drawn every 6 to 12 hours just to make sure that you get that level right. And then they can stay on whatever level it is that they sort of plateau on. And then Coumadin is started, and then that goes on. And we'll talk about Coumadin in a second.
Okay, let me just remind everybody that not all at the vein clinics of Hawaii is doom and gloom, okay? We're talking about these things today because of their specific application to specific problems, which are life-threatening. But there's a lot of stuff that you can go look at. Some of it's just plain good fun. I mean, I'm down at the vein clinics all the time, and I see some really, really happy people having some other really cool things to do. So please take a look at the website. That's veinclinicsofhawaii.com, veinclinicsofhawaii.com. See some of the other stuff that goes on that is not life-threatening at all. It's life-enhancing.
Yes.
I like that, the life-enhancing stuff.
Right.
Okay, so
it's all good.
What's next on that list? Because I know that other people, there's still some things that we got to talk about, some other brands that people are familiar with.
Right. So, the next one is something called Lovenox. Now, Lovenox is one in a group of medications that are under this category. We call these low molecular weight heparin. So it's a specific form of heparin.
Okay.
And it's kind of a fragment of the heparin molecule. Heparin molecule is big. Lovenox and the other low molecular weight heparins are a fragment of that, so they're much smaller. And I think the crux of the thing with Lovenox is that its effects are much more specific. So rather than being a antithrombin 3 agonist and then doing several other duties, it's a little more specific to what's called factor 10. Factor 10 is one of those proteins in the clotting mechanism.
So it goes specifically to work on that.
It goes specifically.
So your call as a physician would be, all right, it's time for Lovenox for this guy or this gal.
Well, yeah, and Lovenox, again, depending on what the situation is and what you're treating, Lovenox is often the better medication for them. Now, Lovenox was also sort of the first step in allowing us to begin to treat people with DVT as an outpatient.
Oh,
because
good.
Lovenox does not need to be given IV. It can be given sub-Q.
Okay.
Sub-Q? Yeah, sub-Q is into the fatty tissue. Right. Often it's in, people will inject it into the belly.
Like diabetic medicine. Right?
Yeah. And so it will thin your blood relatively quickly. Once your blood is thinned with Lovenox, then you can again start Coumadin. And this was again back before we had the newer medications. But so Lovenox we found also could be a bridge to Coumadin therapy, and typically people aren't on Lovenox for a long period of time. They're on Lovenox for a short period of time until something else is then initiated, and again, often it was Coumadin.
Okay, now interestingly enough, these ads that we see on television that we talk about, quite often they'll say in the copy, in the live part, Coumadin / warfarin.
Yeah.
Same thing?
Yeah, warfarin is the genetic name of it. Coumadin is the brand name. Okay. Although, Coumadin's been around so long that, when you say Coumadin, everybody thinks of that specific medication. So again, Lovenox, the activity is much more specific, and because it's much more predictable. We don't have to do all the blood testing with Lovenox, also that we do with heparin. So that makes it, quite a bit more manageable with respect to people taking it as an outpatient. It has become a very good drug. And I guess the other thing about Lovenox is, it has become the medication of choice for DVT prophylaxis for people in the hospital.
Okay. Yeah.
So, you often hear about people being in the hospital and they're given shots into their belly.
Yeah.
And, you can get a little bit of bruising around the injection sites and that kind of thing. But the reason that they are getting that is because we have found that people that go into the hospital, they're at a higher risk for DVT because they're immobilized, they're sick, or they're having surgery, which can lead to DVT. So Lovenox is often the prophylactic medication that's used to prevent DVT in the hospital setting.
Okay. By the way, gang, Doc mentioned just a few minutes ago that some of these things administered subcutaneously will cause a little bit of bruising. I'm happy to report that having some surgical procedures with Doc 6-8 weeks ago, and he told me how this really ugly bruise and some of these things would go away. They're all gone.
No, good.
All gone. It's been a couple of months, like you said. Yeah. But I know that's a lot of people come back every now and again and say, hey, it's a big bruise, man, or this big lump. It's worse. It's terrible. They all go away.
Right.
It's amazing.
Yeah.
But that's because not just of your experience level, but when you did the procedures that I had, predictably, it was going to be ugly before it became pretty again.
And we try to warn people about that. Yeah. One of the good things about what we do is that we can do the procedures that we do in the office with people on blood thinners. Pretty much any blood thinner that they're on, we can do. Some people we need to alter that, but typically we don't stop blood thinners. But unfortunately, people on blood thinners, they're going to bruise more. But we try to warn people of that.
Yeah, I had this thing. I thought, this is never going to go away. It's okay. It's gone. I mean, what can I tell you? It's great.
Yeah.
Okay.
So Coumadin.
Yeah.
We've talked a little bit about Coumadin already, but Coumadin, also called warfarin. People often refer to it as rat poison.
Yeah, that's right.
It is similar to the same, medication that they give to rats to try to get rid of them, because that medication creates internal bleeding, and that's how the rat goes away. Goes to rat heaven. But Coumadin also is a fairly non-specific. Heparin we talked about as being not as specific as Lovenox. Coumadin also does not have one specific action. It affects a number of clotting factors in our blood. These proteins that we have floating around in our blood that have to be activated for clot to form. Coumadin will inhibit the formation of 4 of those clotting factors, 4 different ones. We call those the vitamin K dependent clotting factors, because there's 4 clotting factors that need vitamin K for them to be produced. So those are so that's the way Coumadin works. And these proteins that are clotting factors, we usually we have indicated each one by a Roman numeral, as well as
I was going to ask about that. I saw that Roman numeral list, and I said, where's that going? Well, obviously, you need specifically to track certain of these things. What is it, potency, or is it
Well,
why are there those divisions?
Well, because they have, with scientific study over many, many years, they have found that there is a set of proteins, all of which are needed in order to bring about clotting. And basically what's happening is that each of those factors is being activated, and then once that protein is activated, then it plays a role in the activation of the next protein.
How do you measure that? I mean, how do you take a look and say, okay, Mike, we're going to do this to you. You're going to take these now because.
Well, the Coumadin is something that we need to measure the activity on.
Yeah. Once again, meaning you're pretty much under supervised situation when you're taking that.
Yeah. And again, usually people are by the time they're on Coumadin, they're being treated as an outpatient, but they have to, one of the drawbacks of Coumadin is that you have to go every month or so, even more frequently initially, to measure the activity of the Coumadin in your blood and then adjust it accordingly. So there's a lot of adjustment that has to go with Coumadin. Now, let's just touch on the newer anticoagulants, which are the ones that we see in the commercials at night. And, they're referred to as the new oral anticoagulants, or NOACs, NOAC. They are not vitamin K dependent related type medications like Lovenox. They're much more specific. There's several different types. Eliquis is probably becoming the most common because it has the less bleeding risk and all that sort of thing. But all of them are specific to one of 2 different factors, either 2 or 10, and most of them affect or inhibit factor 10. Their activity is very predictable. We don't have to draw blood. We can treat people, and there's almost an immediate anticoagulation of the blood. So it's been a very good addition to our armamentarium for blood thinning and for anticoagulation. Unfortunately, they're still fairly new, and so consequently they're pretty expensive. But as you mentioned before, if you appeal to the company, often they will find some way to give you a discount.
By the way, gang, I was waiting to drop this one in because I am, through Dr. Julev, taking this medicine, and it has made a measurable difference for me. So that means that, some of these newer things, while they are expensive, I don't want to say you get what you pay for, but sometimes you get what you pay for.
Yeah, sure.
Okay, so if people want to know more about this, and I know that we could do a whole another hour on this.
Yeah, we could.
it is safe to know that, isn't it interesting for you as a physician and as the leader and the medical director of Vein Clinics of Hawaii that these new medications, not only they're available, but they are so effective.
Yeah. Effective and easy to use too. It's really revolutionized our ability to treat DVT as an outpatient.
There you go. Thank you so much for listening. I hope you've enjoyed it. If you want to know more, go to www.veinclinicsofhawaii.com. Veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.